Hello, my name is Nina Wines. I come to you from Sydney, Australia. I'm so excited to be part of this Congress, and I'd like to thank the organisers for doing a superb job managing during these unprecedented times. I'm so fortunate that we can have all this wonderful education online. You'll notice just below me here, I have formulated this QR code. Please feel free to scan it now and to follow me along as I go, as this will take you to my slides. So when we think of neuromodulators, we tend to think of their aesthetic uses only, but the bridge between aesthetic and medical dermatology is becoming narrower and narrower, as dermatologists need to be aware of the medical uses of our lasers to improve many of our conditions. Similarly, there are many medical uses of neuromodulators that we're starting to become aware of. Hyperhidrosis is the obvious one, but today I'd like to turn it up a little and talk to you a bit more about the medical uses of botulinum toxin. I'll also update you on some of the newer and suggested aesthetic techniques as we go along. So as mentioned, I come from beautiful Sydney, Australia, and we're so sad that we can't see you here. So I just thought I'd start by bringing a little bit of my favourite parts of Australia to you, in the hope that this will entice you to come and visit us in easier times. So this is beautiful Whale Beach. How stunning is it? And this is located just 45 minutes outside of Sydney and is absolutely my happy place. It's so stunning, and every day it has something to offer that's a little bit different there on different days. And it's definitely such a beautiful part of the world, and I'd love to show any of you around Whale Beach at any time, and I do hope you come to visit us. So I am Nina Wines. I'm the co-founder of Northern Sydney Dermatology and Laser, with Elizabeth Dawes-Higgs pictured here also. We have a team of derms who work with us, and we are very much a practice that offers a full range of dermatologic services. So we hope you can come and see our practice if you're in Sydney. So today I will talk to you about, I'll just take you through what you can expect from this presentation, the highlights and the insights of this presentation. I'm going to first go through the current and new products in development. Then I'll talk to you about newer dermatologic indications, talk to you about micro and meso Botox, and then we'll end the talk with some new injection techniques. So let's figure this out together. There are so many new products on the market. We are all familiar, of course, with, firstly, before I discuss the products, botulinum toxin is a neurotoxin protein produced by Clostridium botulinum. As you know, there are 7 different types, A to G, but it's type A and B that is commonly used in medicine. The serotype A is what we tend to use for cosmetic injections, or more commonly in dermatology. There are 5 approved brands of type A. And the toxopharmacology for these products is not uniform, and it's absolutely not interchangeable. You may be aware of Botox, which is Ona botulinum toxin. It comes in 50, 100, and 200 ml vials, and Allergan or Abiv distributes this product. Then there is Dysport, which is Abo botulinum toxin, comes in 300 and 500 unit vials. The dose is 2.5 to 3 times that of Botox, and it's made by Ipsen. And then there is Inco botulinum toxin, made by Xeomin, 100 to 200 unit vials. It's stored at room temperature, which is convenient, and it has low protein load, which is supposed to reduce the neutralizing antibody production. It's made by MERS, and we use all these products in our practice. The 2 products that are not available in Australia or FDA approved are Procene or Prosigny, made by Lanzhou Institute in China. Its potency is a bit like Botox, And then there is Meditox, which is made in South Korea, but I believe may have been bought by Allergan. It's like Xeomin, and it's stored at room temperature, and but no reconstitution is required for this product. It comes already made up. So there is a heap of trials being taken place, currently happening at the moment, with genetic engineering, where recombinant non-Clostridium and chimeric Botoxes are being produced, and they're supposed to be a bit more specific in their roles, but the cost of these may be high, and they're trying to find out the cost-benefit analysis for these. But it's a certainly exciting arena of genetic engineering. So watch this space. There's a lot more products becoming available. So we switch now to the recent dermatologic indications of neuromodulators, and I'll just take you through those now. It has been known for some time that botulinum toxin can help rosacea, but why is this? Well, it is increasingly becoming apparent that there's a huge neurogenic component to rosacea. There are, as you know, various subtypes of rosacea, and the pathophysiology of these does vary. Neurovascular signaling and dysregulation of the innate immune system, and imbalance of commensal skin microflora are all possible etiologic factors in rosacea. Neuropeptides such as substance P and VIP and ACH have all been are all increased in rosacea, and these are all activators of mast cells. Botulinum toxin is an inhibitor of ACH and VIP, and it reduces facial flushing, and has been shown to do that in studies, and this is why it's thought to be effective. It also is an inhibitor of mast cells and reduces inflammation, so that's why it's thought to be effective. There's this study by Diane, which was with botulinum toxin with 6 units intradermally injected, a bit like we do for hyperhidrosis, with 0.5 centimeter squares apart, the little injection points, and they showed a significant reduction in erythema with no associated adverse events, i.e. no paralysis of underlying muscles, facial muscles. So it's a very effective technique. And similarly, another study, which was a randomized controlled trial, double-blinded, placebo-controlled, split-face study by Kim et al. In 2009, which showed a valuable benefit for the use in rosacea. So certainly there is evidence that it is a useful adjunct in rosaceal treatment. We switch now to syringoma. Now, this is such a tricky condition to treat. We all know, if we treat it with CO2 laser, we have to put intraocular shields in, and which is an uncomfortable thing for patients to think about. There's also significant downtime from CO2 laser, and syringoma has this tendency to be a little bit more common in people with olive skin for some reason, and post-inflammatory pigmentation is a problem with ablative lasers. So this is a really useful technique. It's thought to work by chemodenervation of the cholinergic nerves, targeting the autonomic control of the eccrine sweat glands. This study showed an example of this patient who had loads of syringoma. It was published in 2021, and literally pretty much small amount injected, and they followed her up 8 months later, and she absolutely remained clear. In this study, they injected about 15 units in total in 3 different injection sites, the center, internal and external periocular areas, and there was no adverse side effects, and she was clear 8 months later. So I think that's going to be useful, certainly something I will try to see if I can get some benefit, because syringoma is certainly a difficult condition to treat. So I move now to talk to you about botulinum toxin and scars. The treatment can be used in various ways for scars, and has been shown in studies to be useful as a prophylaxis to prevent scar formation, meaning injection at the time of surgery or at the time of removal of sutures. for treating existing scars, or for improving the cosmesis of scars whose appearance is exaggerated by movement. So let's look first at established scars and botulinum toxin. Why does it work? Well, it's theorized to work by immobilization of the underlying musculature, and also has been shown to inhibit fibroblast activity, which can minimize tension. There's also some scientific evidence that botulinum toxin reduces human TGF-alpha and affects the fibroblast cell cycle. There's level 1 evidence that it's equivalent to triamcinolone to decrease the keloidal volume, height, and vascularity. That study was published in 2020. It may actually be superior at alleviating pain and itch when compared to TCA, and it may have additional benefits when used in conjunction with TCA. So Goodman published a study to show to point out that scars can become more visible with age. They also can be made worse on dynamic contraction. And in certain areas of the face, there is benefit in using Botox to improve the appearance of existing scars, such as here, and the frontalis would be a good example. Here, as you can see, when this lady contracts, her scarring appears worse, and certainly by treating these areas of the lower face, it would soften the appearance of her scars. And similarly for this man here. And this is a good study case example where a patient underwent combined treatment of Botox and a little bit of filler, and it certainly showed improvement in the appearance of her scar. So I'd like to talk about microbotox, and for those who have not heard of this term, it refers to the injection of small volumes of botulinum toxin, generally into the dermis, rather than into muscles. So small, so it's has a different functionality. We've already kind of talked about that with rosacea and syringoma, but more recent studies show evidence of its effect for sebum control, textural improvement of the skin, pore size reduction, and improvement in skin laxity. It's thought to be due to paralysis of the erector pili muscle or decreased sebum production. Various techniques: you can use an insulin syringe, or some studies showed the use of a dermapen with droplet and then using the dermapen to deliver the Botox into the skin. The studies are relatively many. There's systemic reviews, there's randomized controlled trials, large case studies. The injections are generally placed in a grid-like pattern, 0.5 centimeters to 1 centimeter square apart. But in the studies, the dosage of neurotoxin or neuromodulator varied from 88 units to 50 units. But all studies universally showed no underlying paralysis and minimal adverse side effects. So, so this study, the first study I'd like to bring to your attention was a systemic review of 13 articles, and it showed decreased sebum production in patients. The second study was randomized controls trials showing statistically significant improvement in skin texture and mid-face lifting with both the intradermal and intramuscular injections. And the next study is a randomized control split face study showing also no adverse side effects and improvement. And then the last was just a single center study of Inca botulinum toxin, 92 units showing mid-face lifting, sebum control, and pore size reduction. And this study by Park et al., published in 2020, talks about the intradermal botulinum microdroplet injection technique here, and there are specific injection points that they point out as being effective with different doses in different areas, and that is a useful study to read. So I'd like to lastly talk to you about aesthetic techniques and dosage updates. So when we all know that injecting the forehead can be very tricky, and probably the one area where things can go wrong, such as this TikTok star where she posted her journey following a bad Botox experience where she developed eyebrow ptosis and eyelid ptosis. Similarly, it's easy to miss some parts of the forehead when we inject. And eyebrow asymmetry is a common problem that we do experience. And these are some more difficult things that go wrong with frontalis treatment. So 2 studies have been published in 2020. One is discussing how to improve frontalis and improve the lower forehead approach, because traditionally we inject Botox 1.5 to 2 centimeters above the orbital rim so as to avoid brow ptosis, and that's sort of the traditional recommended guidelines. But this study recommended and showed good results and high patient satisfaction by using a refined technique where the upper forehead was in the safe zone was treated in the traditional fashion, and the lower forehead was treated in a more micro Botox, using a micro Botox technique, and they showed no adverse side effects and high patient satisfaction. And then this study also recently published describes a 121 technique, and this is a reproducible, individualized and customizable approach to getting a perfect result each time for the forehead. So this was published by Pecora, and he describes a 3-step process where he assesses the subject's anatomy and then comes up with develops a bespoke understanding of the patient's desired outcome and shape of eyebrows, and then puts in a customized approach. This customized approach is developed using an assessment grid with 21 potential injection points, and these are anatomically defined by vertical and horizontal lines. The two lines here, the yellow lines, intersect at the mid-papillary point, and then these 5 lines that are basically the inner and outer canthus. And then, of course, the horizontal lines, the upper, the lower, and the mid are equidistant apart. And this allows you a grid-like pattern to ensure that you get a more customizable and better outcome when treating the forehead. So just lastly, before we run out of time, I'd just like to update you on some dosage updates. The study of 150 patients with moderately severe glabellar frown area using botulinum toxin. They did a high-dose study of 20, 50 and 75 units of Xeomin in these subjects, and they found that the higher the dose, the longer it lasts, with 85 days for 50 units and 210 days for 75 units. And certainly the dose effect was much more pronounced at day 120 and day 210. So thank you so much for listening, and you please feel free to view my slides by scanning this QR code. And I do hope that we get to see you in Sydney, and I do hope that you get to go to Whale Beach and many other parts of our beautiful country. And we're so sorry we couldn't host you this time, but I hope you have a wonderful meeting and learn a lot. And I think it's an exciting forum that the team has put together. So thank you very much for inviting me to be part of this, and hope to see you soon. Bye now.